Hello everyone, I am myself Dr. Rajesh Gubba. In this particular session, I'll be discussing a very important valvular heart disease, that is the aortic stenosis. So aortic stenosis is the one which is the valvular heart disease very commonly seen in elderly individuals, also seen in young, but very commonly seen in the elderly individuals. And what will be the most common etiology causing aortic stenosis in elderly individuals is the calcific degeneration of the aortic valve. Whereas in young individuals or in children causing the aortic stenosis, it will be the bicuspid aortic valve. And what will be the pathogenesis for causing aortic stenosis? I'll be discussing that. And what are the very important symptomatology in patients with aortic stenosis? Just remember this mnemonic, that is SAD. Syncopal attack, angina, and as well as dyspnea. These three are the important symptomatologies associated with the aortic stenosis. And the very important examination finding is the characteristic murmur. It is the ejection systolic murmur. And the characteristic pulse, it is also, that is pulsus parvus et tardus. And how will you diagnose this aortic stenosis? The first line investigation will be the two-dimensional echocardiography, which will demonstrate the aortic valve area, aortic valve gradient, and it also will tell you about the aortic jet velocity as well. And coming to the treatment, if the individual is symptomatic, definitely you need to do surgical intervention. So this is in brief about the aortic stenosis. Now what will be the overview of this topic? So I'll just give you the basic introduction of the aortic stenosis and what is the etiopathogenesis for the development of the aortic stenosis. Then I'll be discussing about the clinical features, examination findings in aortic stenosis. How will you manage? That includes the investigations and as well as the treatment of aortic stenosis. So in this particular lines, I'll be discussing this topic of the aortic stenosis. All right. So now, if you take this aortic stenosis, as already I have said you, it is the most common valvular lesion among the elderly individuals. And it is also seen in the young individuals or the young adults, but it is more common in the elderly individuals. And once these patients with aortic stenosis, if they become symptomatic, remember the prognosis of the individual will be bad once they develop symptoms. And first of all, you need to know what is the normal valve area. So normal aortic valve area, it is around 2 to 4 centimeter square, or 3 to 4 centimeter square in an adult. And when will you call the aortic stenosis? We use the word aortic stenosis when the valve area is reduced to less than 2 centimeter square. That is the point when we use the word the aortic stenosis. Now, first, let me just give you the basic idea of the etiology and pathogenesis for the development of the aortic stenosis. As already I have said you, in the etiology and pathogenesis, aortic stenosis in adults, it is mainly due to calcific degeneration of the aortic cusps, right? And this calcific degeneration of the aortic cusps most commonly occurs on a substrate of congenital disease, most commonly occurs on the substrate of congenital aortic disease, that is on the substrate of the bicuspid aortic valve, or there can be trileaflet deterioration, right? There can be trileaflet deterioration, that is they'll have 3 cusps, but these 3 cusps, they undergo deterioration causing the stenosis. And the another important etiology is the rheumatic inflammation. So these are some of the important etiologies that will be causing the aortic stenosis. What is the pathogenesis in these patients? So the process of the aortic valve deterioration and as well as the calcification, it occurs, right? It occurs not only as a passive one, but rather it shares many features. What are those many features which are responsible for the aortic stenosis? It is not just passive. It shares many features with number 1, vascular atherosclerosis. Those individuals who are having the atherosclerosis, they are at increased risk of development of the aortic stenosis. And endothelial dysfunction. Once there is endothelial dysfunction, there is lipid accumulation that can also progress to the development of the aortic stenosis. Then the lipid accumulation, inflammatory cell activation, cytokine release, and upregulation of several signaling pathways. So these are the various mechanisms by which there can be or there will be the aortic valve deterioration and as well as the aortic valve calcification. Now, because of all these events, right, because of endothelial dysfunction or because of lipid accumulation or because of inflammatory cell activation, because of cytokine release, what will be the sequence of events? Let me try to discuss that. So if you see the sequence of events, so initially there will be a fibrocalcific response, right? The fibrocalcific response is established wherein the collagen is deposited. Okay, so there will be a fibrocalcific response, and in response to this, there is the collagen initially it gets deposited, and this particular collagen which is being deposited, this will get differentiated, or this collagen initially it will get deposited within the valvular myofibroblasts. Okay, these valvular myofibroblasts differentiate phenotypically into the osteoblasts and as well as actively producing bone matrix proteins, right? And this osteoblast and actively producing bone matrix proteins, they allow the deposition of the calcium hydroxyapatite crystals. These are the changes that happens within the aortic valve, right? These are the changes that happens within the aortic valve. So initially what happens, there will be a fibrocalcific response is established. As a process of this fibrocalcific response, the collagen is deposited in valvular myofibroblast, which will get differentiate phenotypically into osteoblast and actively producing the matrix proteins, and that will allow the deposition of the calcium hydroxyapatite crystals. That is one mechanism by which there can be aortic stenosis. The another mechanism is the genetic polymorphisms. See, genetic polymorphisms involving vitamin D receptors, genetic polymorphism involving the estrogen receptor in postmenopausal women, then inflammatory cytokines like interleukin 10 and as well as the apolipoprotein E4. All these, they have been linked to the development of the calcific aortic stenosis. Okay, so genetic polymorphism of vitamin D receptor, then estrogen receptor, interleukin 10 and as well as apolipoprotein E4, all these have been linked to the development of the calcific aortic stenosis. All right, now the next important point is there are certain risk factors, right? There are certain traditional atherosclerotic risk factors. They have been associated with the development and as well as the progression of calcific aortic stenosis. What are those atherosclerotic risk factors that are associated with the development and progression of calcific aortic stenosis? These include number 1, hypertension, number 2, LDL cholesterol, number 3, lipoprotein A, diabetes mellitus, smoking, chronic kidney disease and as well as metabolic syndrome. Remember, all of these, they are the traditional atherosclerotic risk factors which are responsible for the development and progression of the calcific aortic stenosis, which are very, very important. Among all these, the hypertension, diabetes mellitus and as well as the dyslipidemia, these three itself, they account for almost 1/3 of the population attributed for severe aortic stenosis. Okay, so what all we have discussed now in the etiopathogenesis? Number 1, fibrocalcific response. Okay, and number 2, genetic polymorphism. Next, we have discussed the risk factors or atherosclerotic risk factors that will cause the development and progression of the calcific aortic stenosis, right? Now, then followed by that, you need to understand that if there is presence of the aortic valve sclerosis, this aortic valve sclerosis, it is associated with excess risk of cardiovascular death, and it is also associated with excess risk of myocardial infarction among persons of age more than 65 years. Okay, so presence of the aortic valve sclerosis, it is associated with increased risk of cardiovascular death, increased risk of myocardial infarction in individuals of age more than 65 years. And if you see the rate and as well as the extent of the progression to the level of the valve obstruction, obstruction means where there will be stenosis. So initially you will have the aortic valve sclerosis, and that will progress to the development of the stenosis. So the rate and extent of progression to the valve obstruction, right, it vary among the individual patients. Right, they vary among the individual patients. All right, then, so among all the various etiologies, which are very, very important etiologies, the very important etiologies, if you observe, in elderly individuals, the most common cause will be calcific aortic stenosis, right, or where there will be calcific degenerative aortic stenosis. Then you take in the young individuals, the most common cause of the aortic stenosis will be bicuspid aortic valve, right, bicuspid aortic valve, and the other causes will be rheumatic fever and as well as the radiation. Right, the other causes will be rheumatic fever and as well as the radiation. So these are all the various etiologies that are responsible for the development of the aortic stenosis. And this particular slide, it gives you the pathogenesis of the calcific aortic stenosis. So first and foremost, what is that you will observe? Lipid and inflammatory cell infiltration. So you see there is lipid infiltration and as well as the inflammation. So lipid and inflammatory cell infiltration will occur across, right, will occur across the damaged endothelium, right, will occur across the damaged endothelium. Now, once there is lipid accumulation or lipid infiltration and as well as the inflammation, that will initiate the cascade of events, right, that will initiate the sequence of events. Okay, and this particular sequence of events, that includes the fibrosis, and there will be accumulation of the calcium hydroxyapatite. This fibrosis and calcium hydroxyapatite, these are the one which will be responsible for the calcific aortic stenosis. Okay, so this is in brief about the pathogenesis. And what are the major etiologies we have discussed? Now let me tell you, in rheumatic fever, like what is the mechanism of development of the aortic stenosis. So if you see the rheumatic disease of the aortic leaflets, what they produce initially, they produce the commissural fusion, right? So you have the three leaflets. Okay, so what are these three semilunar valves? Okay, these semilunar valves, they undergo the commissural fusion, and this particular commissural fusion results in a bicuspid appearance wall, right? This results in bicuspid appearing valve. Okay, now after this, what will be the progression? What happens is, on this particular bicuspid appearing wall, these leaflets, they are more susceptible to trauma, right? These leaflets, they are more susceptible to trauma. Ultimately, these events leads to fibrosis. These events leads to calcification and further narrowing. Right, further narrowing. So this will be the sequence of events in the rheumatic disease. So basically, initially it will be a commissural fusion, and that will give you the appearance of the bicuspid appearing valve. And this particular bicuspid appearing valve, it is susceptible to trauma, ultimately leads to fibrosis, calcification, and further narrowing. Okay, and you have to remember that by the time the obstruction to the left ventricular outflow tract causes serious clinical disability, remember what happens is the valve, right, the aortic valve, it becomes rigid and as well as a calcified mass. Okay, and when you do a careful examination of this rigid and calcified mass, it becomes impossible to determine the etiology of the underlying process. Okay, so by the time the obstruction to the left ventricular outflow causes serious clinical disability, by that time the valve becomes rigid, calcified mass. Okay, and careful examination may make it difficult or even impossible to determine the etiology of the underlying process. And this particular rheumatic aortic stenosis is almost always, it is associated with the involvement of, right, it is associated with involvement of the mitral valve, where there can be MR or MS, or it is associated with the aortic regurgitation. Okay, rheumatic AS is almost always associated with the involvement of the mitral valve or the aortic regurgitation. And the other etiology is the mediastinal radiation. Even this also can cause aortic stenosis. And what is the mechanism? This mediastinal radiation will cause late scarring of the aortic valve. There will be fibrosis of the aortic valve, and there will be calcification of the aortic leaflets. Right, there will be calcification of the aortic leaflets. So these are the three mechanisms by which the mediastinal radiation will cause the aortic stenosis. Then the next important is the bicuspid aortic valve, very common in young individuals, causing the aortic stenosis. Okay, and if you take male to female ratio of the bicuspid aortic valve, male to female ratio, males, they are having more predominance than compared to that of females. So the ratio is around 2 to 4 is to 1. That is the incidence of the bicuspid aortic valve, and it is very commonly seen in young individuals, and it is an inherited disorder. And the type of inheritance, it is an autosomal dominant type of inheritance with incomplete penetrance, right, with incomplete penetrance. And the other way by which it can get inherited is, it can be inherited as an X-linked component. Okay, now this X-linked component, it is suggested by the prevalence of bicuspid aortic valve among the patients with the Turner syndrome. Right, among the patients with the Turner syndrome. So two types of inheritance, autosomal dominant and as well as the X-linked inheritance. And you need to understand that the prevalence of bicuspid aortic valve, right, the prevalence of bicuspid aortic valve among the first degree relatives, it is nearly around 10%. And what are the genes that are being mutated which are responsible for your bicuspid aortic valve? Remember, it is not a single gene defect. Okay, the single gene defect to explain the majority cases has not been identified. So there are mutations in multiple genes. Example, Notch1 gene, number 2 GATA5, and then right, and then GATA4. So these are the three genes mutations which have been identified for the etiology of development of the bicuspid aortic valve. And this bicuspid aortic valve, it is associated with the other cardiac anomalies. What are the other cardiac anomalies which are being associated? That includes the ascending aortic aneurysm, right? Ascending aortic aneurysm, and the another important associated cardiac anomaly include the coarctation of aorta. But which is more common? The more common will be the ascending aortic aneurysm. That will be the more common than compared to that of the coarctation of aorta associated with the bicuspid aortic valve, right? And you need to understand that these aneurysms, they are at risk of the dissections. Okay, so they can also have the associated aortic dissection as well. And this particular bicuspid aortic valve, it is a component of a complex congenital heart disease. And what is that complex congenital heart disease? That will be the Schwann's complex. What are the components of the Schwann's complex? There are totally 4 components. That includes, number 1, the presence of the supravalvular mitral membrane, right? So you have a mitral valve annulus. Above that, you have a membrane, supravalvular mitral membrane, then subaortic stenosis, right? Then aortic valve anomalies like bicuspid aortic valve, and then followed by that the coarctation of aorta. So these are the 4 components of the Schwann's complex, right? Now, this aortic stenosis, it is one of the obstructive lesion at the level of left ventricular outflow tract. But there are many other differential diagnoses as well. So if you see the other forms of obstruction to the left ventricular outflow tract, we have 3 other lesions. Number 1, hypertrophic obstructive cardiomyopathy, right? Then we have subaortic stenosis, right? And this subaortic stenosis, it is either membranous subaortic stenosis or it is fibromuscular subaortic stenosis, right? Then the another important etiology is supravalvular aortic stenosis, right? Supravalvular aortic stenosis. So these are the other forms of obstruction to the left ventricular outflow tract, right? And how can you differentiate all these causes, right? How can you differentiate HOCM, subaortic stenosis, and supravalvular aortic stenosis? So you can differentiate all these on the basis of the cardiac examination and as well as the imaging study, that is the 2-dimensional echocardiography. So these are the various ways by which you can differentiate the aortic stenosis from the other causes of the LV outflow tract obstruction. Now let me discuss the pathophysiology in case of the aortic stenosis. So first and foremost, right, so what has happened to the valve area? The valve area has been reduced to less than 2 centimeters square. So there is an obstruction to left ventricular outflow, right? This particular obstruction to the left ventricular outflow produces a systolic pressure gradient, right? This will produce a systolic pressure gradient. And how much will be that systolic pressure gradient? It will be definitely more than 10 millimeters of mercury between the left ventricle and as well as the aorta. So this is a criteria to call it as aortic stenosis. The gradient should be more than 10 millimeters of mercury. And remember, if there is severe obstruction suddenly, this can happen usually experimentally. Like experimentally, let us just assume that there is severe obstruction which is sudden in onset. Then in such case, what will happen to the LV? How will the left ventricle respond? Left ventricle responds by dilatation, right? Left ventricle responds by dilatation, and there will be reduction of the stroke volume, right? There will be reduction of the stroke volume. So this will be the response of the LV if there is LV obstruction which is sudden in onset, which usually, like, let us just assume experimentally. But however, in some patients, the obstruction may be present at birth itself, or there is the obstruction increasing gradually over the course of many years. Then in this case, what happens is the left ventricular contractile performance, right? Left ventricular contractile performance, how is it maintained? Left ventricular contractile performance is maintained by the presence of, right? It is maintained by the presence of concentric left ventricular hypertrophy. Okay. So if the obstruction, if it is gradual in onset or if it is present since birth, then the contractile performance, it is maintained by the presence of the concentric left ventricular hypertrophy, right? And the next important point you need to know is that a large transaortic valve pressure gradient may exist for many years. Okay, it may exist for many years without reduction in the cardiac output or without development of the left ventricular dilatation. So for many years it will be only concentric left ventricular hypertrophy, and this concentric left ventricular hypertrophy is the one which is causing the contraction more and thereby maintaining the cardiac output. So for many years without reduction in the cardiac output or without the development of LV dilatation, the individual will exist. But ultimately, what are the changes? So finally, the changes that happens in the aortic stenosis is, at one point of time, the left ventricular hypertrophy, it becomes maladaptive, right? It becomes maladaptive, and subsequently what happens is left ventricular systolic function declines. When will the systolic function decline? Systolic function declines because of increased afterload. So there is an afterload mismatch. So the stenosis is so severe and afterload on the left ventricle is so high, the left ventricle is unable to take that particular afterload which is coming from severe aortic stenosis, and that is the point when the left ventricular systolic function declines, right? And abnormalities of diastolic function progresses. So there will be abnormality of there will be abnormality of the diastolic function that will progress. Okay, and subsequently there will be irreversible myocardial fibrosis, right? Irreversible myocardial fibrosis develops. So these are the ultimate changes that you come across in patients with the aortic stenosis. Now you see, because of this, what all things happen in the left ventricle? So because of abnormality of the diastolic function, there will be increase in the LV end diastolic pressure, right? Because the ventricular systolic function is declined because of increased afterload, and then on the same time there is left ventricular diastolic dysfunction. Why? Because of left ventricular hypertrophy. So there is increase in the left ventricular end diastolic pressure, and this will further cause increase in the left atrial pressure. So left atrial pressure is elevated so high because of increase in the LV end diastolic pressure. So that is the reason why, because of increased left atrial pressure subsequent to increase in the left ventricular end diastolic pressure, you know how the left atrium contracts? Left atria, it contracts forcibly, right? Left atrial contraction increases, and that will correspond to the development of the fourth heart sound. So all these, why they are developing? That is because when the left ventricular hypertrophy becomes maladaptive, and when the left ventricular systolic function declines because of the afterload mismatch, there will be abnormality of the diastolic function, and that will cause irreversible myocardial fibrosis. So all these will lead to the following changes. Okay, then the next important point you need to know is, when will you call severe aortic stenosis? What should be the criteria to call it as the severe aortic stenosis? If the mean systolic pressure gradient, if it is more than 40 millimeters of mercury, right, that is the gradient between the aorta and as well as the left ventricle, if it is more than 40, it is considered as severe aortic stenosis. But even though severe aortic stenosis, the individual may have normal cardiac output in early stages of the severe aortic stenosis, right? Or when do you call severe aortic stenosis is when the effective aortic orifice area, when it is reduced to less than 1 centimeter square, then also there is a criteria to call severe aortic stenosis, right? And the other thing is, the aortic valve area, it is reduced to less than approximately 1/3 of the normal orifice area, right? It has been reduced to less than 1/3 of the normal orifice area. These are the points to tell that the individual is having severe aortic stenosis, where there is severe obstruction, right? Where there is severe obstruction to left ventricular outflow, right? Severe obstruction to the left ventricular outflow, right? Then the next important point you need to know is that we have discussed LV end diastolic pressure increases and the left atrial pressure increases, but you need to know that when will you consider that there is diminished compliance of the hypertrophied left ventricle? See, if there is elevated left ventricular end diastolic pressure with preserved ejection fraction, that tells that the individual is having decreased compliance of, right, that tells that there is decreased compliance of hypertrophied left ventricle. Okay, see, it is only when there is decrease in the compliance of the hypertrophied left ventricle, the LV end diastolic pressure increases with preserved ejection fraction. Okay, so even though there is increase in the LV end diastolic pressure, in the resting state, the cardiac output, it is within the normal limit. In the resting state, the cardiac output is within the normal limit. But whenever the individual is doing the exercise, then the cardiac output decreases. Okay, so this cardiac output, it fails to rise with exercise. Why it fails to rise normally during the exercise will be discussed. So like what the patient is having is the fixed cardiac output. It is not rising even during the exercise, and because of that, what will be the consequence we'll be discussing. And you have to understand that the left atrial pressure is elevated. So once there is left atrial pressure elevated, there will be left atrial dilatation. Okay, and once there is left atrial dilatation, remember the abnormality that can happen is development of atrial fibrillation. Okay, so once there is atrial fibrillation, what happens? There is loss of the atrial contraction, right? Loss of the atrial contraction. Once there is loss of atrial contraction, there will be rapid progression of the symptoms. Why? I'll tell you. Why? Because there is increased LV end diastolic pressure in aortic stenosis, and in response to that increased LV end diastolic pressure, left atria is trying to contract very strongly to push the blood into left ventricle. But upon that, if there is development of atrial fibrillation, what happens? I mean, there is loss of adequate atrial contraction. So thereby the LV filling does not occur properly. Once the LV filling does not occur properly, then the symptoms, they will further worsen very badly. Okay, so what happens is late in the course, the contractile function deteriorates. Why? Already I have said you, because of the afterload excess, right? Because of the afterload excess. So because of which the cardiac output decreases. Okay. Then LV end diastolic pressure increases. Then left atrial pressure increases. Then pulmonary capillary wedge pressure increases, and that can cause the pulmonary edema. And because of this pulmonary edema, the patient will have dyspnea. And because of this decrease in cardiac output, there will be hypotension. And because of hypotension, the patient can have the syncopal attack. Right? The patient can have the syncopal attack. And subsequently, right, the pulmonary capillary wedge pressure is increased. Subsequently, there will be increase in pulmonary arterial pressure. And that will further cause increase in the right ventricular pressure. Right? That will cause further increase in the right ventricular pressure. Okay. Now, next important is, if you take the aortic stenosis, it is most commonly seen in elderly individuals. And in elderly individuals, they are at increased risk of development of coronary artery disease as well. That is because of the atherosclerotic degeneration of the coronary arteries. So, what you have to understand is that left ventricular performance can be further compromised if there is superimposed coronary artery disease along with aortic stenosis. Right? Along with aortic stenosis, if there is superimposed coronary artery disease, left ventricular performance further it gets diminished. Okay. So, once the left ventricular performance decreases, the individual goes into a state of left ventricular systolic failure. Once there is left ventricular systolic failure, what type of aortic stenosis you come across? That is, you come across low flow, low gradient aortic stenosis. Now, what do you mean by this? Low flow means it is defined as the stroke volume less than 35 ml per meter square. Normally, how much is the stroke volume? Normal stroke volume is around 60 to 70 ml per single contraction, but here it is less than 35 ml per meter square. Low gradient aortic stenosis. So, how much will be the mean gradient? The mean gradient will be less than 40 millimeters of mercury. See, to call it a severe aortic stenosis, it should be more than 40. Right? Whereas in low gradient aortic stenosis, the mean gradient is less than 40 millimeters of mercury. Right? Now, why and how? See, this you come across in patients with severe aortic stenosis. Why? Because in severe aortic stenosis, there will be development of left ventricular systolic failure. Once there is development of left ventricular systolic failure, what will happen to the cardiac output? Decreases. Okay. And once the cardiac output decreases, what will happen to the gradient which has been developed between the left ventricle and aorta? The gradient is also, right, the gradient which is developed between the left ventricle and as well as the aorta decreases. Why? Because of LV systolic failure, left ventricle is unable to contract strongly. That is the reason why the gradient between the left ventricle and aorta decreases. So that is called. And once there is systolic failure, what will happen to cardiac output? Decreases, and that will cause decrease in stroke volume also. And that is what is nothing but low flow, low gradient, severe aortic stenosis, right? And so that is one part of the pathogenesis. Next part is the hypertrophied LV. It causes increase in the myocardial oxygen demand, right? It causes increase in the myocardial oxygen demand. So because of increase in the myocardial oxygen demand, what happens is the patients will develop the angina. So it is actually a mismatch. There is a hypertrophy, right, where there is increase. So this increased oxygen demand is due to left ventricular hypertrophy. And at the same time, there is a coronary artery disease. And because of coronary artery disease, the blood supply to the myocardium is reduced, and that will result in angina. So on one side, the demand is more, and on the other side, the supply is less, and that will result in the angina. Okay. So you have to understand that even in the absence of the obstructive coronary artery disease, still the patients with aortic stenosis, they can develop angina. Why is this? That is because of increased oxygen demand and as well as the decreased supply. So this will contribute to the development of the angina, right? And because of the decreased blood supply to the hypertrophied left ventricle in aortic stenosis, what can happen is subendocardial ischemia can develop, right? So subendocardium is especially vulnerable to the ischemia, right? Why? By this mechanism, increased demand and decreased supply. So this is about the pathogenesis. Very simple. What all we have discussed? So initially there will be left ventricular systolic failure, right? That will cause increase in the LV end diastolic pressure, right? And that will cause increase in the LA pressure, increase in the pulmonary capillary wedge pressure, and then increase in the pulmonary artery pressure. Increase in the pulmonary capillary wedge pressure will cause pulmonary edema, due to which there is dyspnea, right? LV systolic failure is there, so cardiac output is reduced. So these patients, they will have hypotension and as well as the syncopal attack. That is one thing. And another thing is there is ischemia, because of which there is angina. So this is what is a triad of the pathogenesis of the aortic stenosis. So if you see the symptoms of the aortic stenosis, it is rarely of clinical importance until the valve orifice area is narrowed to less than 1 centimeter square, right? So until the valve area has been narrowed to less than 1 centimeter square, the individual will not be much symptomatic. Now, even in case of severe aortic stenosis, so even though the valve area is less than 1 centimeter square, right, even severe aortic stenosis may exist for many years without producing any symptoms. Why? Because of the ability of hypertrophied left ventricle, right? Because of the ability of hypertrophied left ventricle to generate elevated intraventricular pressure. Okay, IVP stands for intraventricular pressure, and this elevated intraventricular pressure is required to maintain the normal stroke volume. Okay, it is required to maintain the normal stroke volume. Okay, so even though less than 1 centimeter square, for a period of time the individual may be asymptomatic because of this hypertrophied left ventricle increasing the intraventricular pressure, which is required to maintain the adequate stroke volume. Once these patients, they become symptomatic, remember, the LV ejection fraction reduces. Okay, and these are the candidates who require valve replacement or they require the valve repair. Okay, this is what you need to do once the individual becomes symptomatic. And remember, most patients, right, most patients with pure or predominant aortic stenosis, when do they become symptomatic? They become symptomatic around 6th or around 8th decade of life. Okay, if it is like pure or predominant aortic stenosis, they have gradually increasing obstruction over years and they do not become symptomatic until 6th to 8th decade of life. Whereas you take in patients with bicuspid aortic valve, they develop the significant valve dysfunction in 1 to 2 decades sooner. Okay, so these patients, they become symptomatic sooner, right, within 1 to 2 decades sooner. Whereas sclerotic or degenerative aortic valve, they become symptomatic later. Now, what are the 3 cardinal symptoms of the aortic stenosis? Just remember this mnemonic, that is SAD. Okay, so SAD stands for the number 1, syncopal attack, A stands for angina, D stands for dyspnea, right? But if you see the sequence of the development of the clinical features, it is exactly the reverse of mnemonic. That is, just remember the mnemonic thus. Okay, so in this sequence the clinical features develop. So initially there will be development of dyspnea, then angina, then there will be development of the syncopal attack, right? So once there is history of insidious progression of fatigue, so initially these patients, they present with fatigue, that is because of decrease in cardiac output, and there can be also development of the dyspnea, right? And this fatigue and as well as dyspnea, both of them, they are associated with decrease in the daily activities of the individual, right? It is associated with the decrease in the daily activities of the individual. Now what will be the mechanism of the dyspnea, right? What will be the mechanism of the dyspnea? Just now we have already discussed in the pathogenesis also. See, the mechanism of dyspnea, it is mainly because of elevation in the pulmonary capillary wedge pressure, right? And this increase in the pulmonary capillary wedge pressure, it is secondary to increase in the LV end diastolic pressure. Okay, so this increase in pulmonary capillary wedge pressure will cause pulmonary edema, and this is what is responsible for the development of dyspnea. And what about the mechanism for the development of angina pectoris? This also we have discussed in the pathogenesis. Angina pectoris usually develops somewhat later, that is after the dyspnea. And what does it reflects? It reflects the imbalance, right? It reflects the imbalance between increased oxygen demand, right? Increased myocardial oxygen demand and reduced oxygen supply. So imbalance between these two will result in the development of the angina pectoris. And remember, if the age of the individual is more than 65 years, along with the aortic stenosis, there can be concomitant coronary artery disease as well. So there can be coexisting coronary artery disease along with aortic stenosis if the age of the individual is more than 65 years, and this coronary artery disease also can contribute to the development of angina. But even though in the absence of coronary artery disease also, there can be development of angina as well. And the last important symptomatology will be the exertional syncope. So why is that? That is because number one, there is fixed cardiac output in the individual even during exercise, right? So even during exercise, the cardiac output is not increasing in aortic stenosis. It's a fixed cardiac output. And during exercise, what happens? There will be vasodilatation in the exercising muscles. So because of vasodilatation in the exercising muscles, there is decline in the arterial pressure in the blood vessels supplying to the exercising muscles. So whatever the cardiac output has occurred, that will go to the exercising muscles, right? That will go to the exercising muscles. And there is inadequate vasoconstriction in non-exercising muscles, like you take the facial muscles and all, non-exercising. In the non-exercising muscles, there is no adequate vasoconstriction as well. And that will cause decrease in the cerebral perfusion. That will result in the syncopal attack. And not only that, in patients with aortic stenosis, if there is coexisting arrhythmia like atrial fibrillation or the development of ventricular fibrillation, there can be sudden fall in the blood pressure of the individual causing the syncopal attack. So patient with aortic stenosis had a sudden syncopal attack. One of the differential diagnoses that you need to think is development of the arrhythmias. Now, at one point of time, there will be development of the LV failure, wherein you have the symptoms of the LV failure. What will be that? There can be paroxysmal nocturnal dyspnea, right? And subsequently, they can have the development of orthopnea, right? And subsequently, they will have dyspnea on exertion and as well as dyspnea at rest. Okay, so this is what happens as the advancement of the disease occurs. And in these patients with aortic stenosis, we have discussed that, right, increase in pulmonary capillary wedge pressure causes increase in pulmonary artery pressure. That is nothing but your pulmonary hypertension, and this pulmonary hypertension leads to right ventricular failure. So once there is right ventricular failure, what happens? There will be systemic venous congestion, right? There is systemic venous congestion, right? There will be hepatomegaly, and that too a tender hepatomegaly, and the atria is distended, and that goes into an atrial fibrillation, and there will be tricuspid regurgitation. And why is this due to? This will be the functional tricuspid regurgitation. Okay, that is because of increase in pulmonary arterial pressure. There will be increase in the right ventricular pressure, and this increased right ventricular pressure is the one which is responsible for tricuspid regurgitation, and that too a functional tricuspid regurgitation. And remember, whenever there is aortic stenosis, along with that, if the mitral stenosis also coexist, what happens? There will be reduction in the flow. There will be reduction in the cardiac output in the early stages of the aortic stenosis itself. Okay, and because there is decrease in the cardiac output which is caused by the mitral stenosis also, the many changes whatever you come across in isolated aortic stenosis will not be there if there is coexisting mitral stenosis. I'll repeat again. If there is associated mitral stenosis, there will be decrease in the cardiac output. Why? Because the amount of blood which is moving from LA to LV will be reduced, and because of obstruction, the movement of the blood whichever has come into the LV from LA, even that also does not go into the aorta, so there will be significant decrease in your cardiac output. And whatever the signs that you come across in isolated aortic stenosis, all that they may change or they may alter if there is aortic stenosis along with the mitral stenosis. And if suppose if there is concomitant aortic regurgitation, then in such case what happens is there will be increased trans-aortic pressure gradient, right? There will be increased trans-aortic pressure gradient. Why there is increased trans-aortic pressure gradient? That is due to, right, that is due to higher aortic valve flow rates, right? That is due to higher aortic valve flow rates, you know, there is increase in the trans-aortic pressure gradient, right? Then these are the symptomatologies, that is syncopal attack, angina and dyspnea, but initially it will be dyspnea and then angina and then syncopal attack, right? Then you need to know examination. So if you observe the heart rhythm, right, it is usually regular until the later course of the aortic stenosis. In the later course of the aortic stenosis, what happens? There will be development of the atrial fibrillation because of the distension of the atria. And once there is atrial fibrillation, the rhythm, it will be the irregular rhythm. Okay, rhythm will be the irregular rhythm. Okay, right. Then the next important is about the blood pressure. So hypertension occurs commonly among the old adults with aortic stenosis. Why? Because in old adults, there will be also sclerosis of the blood vessels, right? There will be sclerosis of the blood vessels. And because of the sclerosis of the blood vessels, there can be development of the hypertension. But as the severity of the aortic stenosis increases, in the late stages, right? In the late stages, the stroke volume declines. Right? Once the stroke volume declines, systolic blood pressure decreases. And once the systolic blood pressure decreases, there will be a narrow pulse pressure. Right? There will be a narrow pulse pressure. So narrower is the pulse pressure, severe is your aortic stenosis. Then you take the carotid arterial pulse. In the carotid arterial pulse, you will see that there is a slow rise in the volume, right? Slow rise with delayed peak. And this slow rise with delayed peak, this we call it as a characteristic pulse called pulsus parvus et tardus. So this will be the characteristic pulse in patients with the isolated aortic stenosis. And not only that, whenever you palpate the carotid, you will feel a thrill or you will have an anacrotic shudder. This we also call it as the carotid shudder. And this carotid shudder, remember, it is a palpatory finding, right? It is a palpatory finding over the carotid, right? And in elderly individuals, what happens is, in elderly individuals, there is stiffening of, right? In elderly individuals, there is stiffening of the arterial wall. Now, because of the stiffening of the arterial wall, what happens is this carotid shudder, it will get masked, right? Because of the stiffening of the arterial wall, the carotid shudder will get masked. That is what you come across in patients with aortic stenosis in elderly individuals. And when you take the JVP, there will be a prominent A wave. Okay, why there will be prominent A wave, right? What is the mechanism of the prominent A wave? That is because of increase in the right ventricular pressure. The right atria, it has to strongly contract in order to send the blood into right ventricle. Right ventricular pressure is elevated now. So right atria has to contract very strongly to send the blood into right ventricle, and that stronger right atrial contraction will give rise to the prominent A wave. Now, if you take the LV apical impulse, LV apical impulse, most of the time it is present in the left fifth intercostal space, half an inch medial to mid-clavicular line, which is the normal position. But when occasionally, sometimes it is being displaced laterally, right? It is being displaced laterally. And when will this happen? In the later course of the disease. Whenever there is a development of right ventricular hypertrophy, then because of pulmonary arterial hypertension, then the LV apical impulse will be displaced laterally. And these patients, they have double apical impulse. Why is that you are having this double apical impulse? The double apical impulse is nothing but the palpable S4, right? That is nothing but the palpable S4, it may be appreciated, right? And in which particular position of the individual this palpable S4 is better appreciated? It is better appreciated in the left lateral recumbent position. In left lateral recumbent position, it is better appreciated. I have already said you, why are you having this palpable S4? Because the atrial contraction is not a normal atrial contraction here. It's a stronger left atrial contraction and a stronger right atrial contraction. Why? Because the diastolic pressures of the ventricles are high, and in order to send the blood from atria to the ventricle, atria has to contract very strongly, and once the atria contracts strongly, you get this palpable S4, right? And next thing is the presence of the thrill, and this particular thrill, it is present at the base of the heart on right side of the sternum, right, on right side of the sternum. And this thrill, you will be able to appreciate it better when the individual leans forward, right? When the individual leans forward, then you will be able to appreciate this particular systolic thrill better on the right side of the sternum in the second intercostal space or in the suprasternal notch. Then very important part of the examination is the auscultation. Okay, so if you take this particular auscultation, right, so you have the first heart sound, then second heart sound, and then again first heart sound. And in second heart sound, you have A2 and then P2, right? A2 and as well as the P2. So what will happen to the A2? What will happen to the intensity of the A2? So the intensity of the A2, it will be soft because it's a sclerosed aortic valve closing slowly. So you have soft A2, and mechanism of this soft A2 we have discussed in detail in the section of the heart sounds. Okay, and these patients, as the severity of the aortic stenosis increases, what happens is, you see here, this is the left atrium and this is the left ventricle giving rise to the aorta, and this will be the aortic valve. And subsequently here, like you have the pulmonary valve on the right side. So what has happened to the duration of the LV contraction in case of aortic stenosis? The duration of the LV contraction is prolonged. When duration of the LV contraction is prolonged, what happens is the A2, it will get delayed, right? A2, it will get delayed. So A2, it can merge with the P2, right? Where you will listen this sound as a single S2. And at one point of time, in very severe aortic stenosis, the duration of the LV is so prolonged that RV contracts, right ventricle contracts, but still LV is contracting. Okay, so in such case, you will listen P2 first and then followed by that A2. And this is what is called as paradoxical split of the second heart sound, right? This is what is called as paradoxical splitting of the second heart sound. And you have to understand that this A2, you will be able to hear it properly only if the valves are pliable in case of the aortic stenosis. If suppose, if the valves are calcified, then you will have a soft A2. The intensity, it diminishes. And next important thing, I said you that these patients, they have stronger left atrial contraction, and that contributes to the development of S4. And the atria contracts in the later part of your diastole. Okay, so that is the reason why I have put in the later part of the diastole S4. And whenever there is development of the LV failure or RV failure, then you will have S3. Right, then you will have S3, that is nothing but your ventricular gallop, right? Then very important part of the discussion, apart from the sounds, the murmur. So if you see the murmur of the aortic stenosis, right, where do you listen this? You listen this exactly in the mid part of the systole, right? So exactly in the mid part of the systole, the intensity will be very high, and this we call it as the mid-systolic murmur, or we call this as the ejection systolic murmur. Okay, we call this as mid or ejection systolic murmur. And this mid or ejection systolic murmur, it commences shortly after the S1. And when will the intensity peak? The intensity, it peaks where? In the middle of the ejection. Right, in the middle of the ejection, the intensity peaks. Okay, and then finally it ends just before the aortic valve closure. That is about the murmur. And if you see the character of the murmur, it is a low pitched murmur, right? And it is rough in character. Not only rough and rasping in character. And where is it heard? Loud. It is being, this murmur, it is heard loud at the base of the heart, right? At the base of the heart, and most commonly in the second right intercostal space. Second right intercostal space, the murmur is heard loud. And this particular murmur, it will also radiate to the carotids, right? It will also radiate to the carotids. And there is a very, very important phenomenon that you need to know, and that we call it as the Gala-Verdin effect or the Gallowerdin phenomenon. What is that? The murmur which is being heard in the second right intercostal space, loud, that will be transmitted towards the apex. Okay, the murmur which is heard best in second right intercostal space, that will be transmitted to the apex of the heart. And this particular transmission to the apex of the heart is what is nothing but the Gallowerdin effect or the Gallowerdin phenomenon. Most of the time, this Gallowerdin effect or Gallowerdin phenomenon, right, we confuse usually with the murmur of mitral regurgitation, because mitral regurgitation murmur is also heard at the apex, and that is also the systolic murmur. Then how will you able to differentiate that? The MR murmur, it is usually pansystolic murmur, and this pansystolic murmur of the MR, that will be radiating to the axilla, but your Gallowerdin effect will not radiate to the axilla. So that is how you can differentiate these two. And this particular murmur, ejection or mid systolic murmur, what is the grade? The grade is at least 3/6, right? At least 3/6. Okay, then you have to understand that if there is mild degree of obstruction, right, if there is mild degree of obstruction, then in such case, how will be the murmur? The murmur, it will be soft, and murmur will also be brief. And other scenario where the murmur will be soft and brief is whenever there is severe aortic stenosis causing heart failure, and because of which there is decrease in cardiac output, then also the murmur will be soft and as well as brief. Why? Because once the individual develops the heart failure, what happens to the gradient? The gradient decreases, which is nothing but your low flow, low gradient aortic stenosis. And whenever there is low flow, low gradient, the intensity of the murmur also decreases. Okay, right. So this is about the auscultation in patients with the aortic stenosis. So you need to know the abnormality in second heart sound, and you have additional third and fourth heart sounds. Then you need to know about the cardiac murmur in aortic stenosis. So this is about the auscultation. And next important thing we'll be discussing is the examination, that is laboratory examination, right? Definitely the first line investigation will be 2D echo. And what are the other investigations, and what is that you look in 2D echo, and how do you manage, or how do you treat these patients? Let us discuss now. So in the laboratory examination, like what exactly will be the first line investigation? That will be the 2D echo, and the confirmatory test will be the catheterization, which is an invasive procedure. So usually the cardiac catheterization, which is an invasive procedure, we usually don't do it until unless required. But otherwise, the diagnosis of the aortic stenosis is made by the first line investigation, that is two-dimensional echocardiography. So what are all the various investigations and what are the specific changes, right? There will be certain changes in the ECG, chest X-ray, 2D echo, CT, and as well as MRI. And what is the indication of CT and as well as MRI? I'll be discussing now. So you take the ECG in case of the aortic stenosis. In aortic stenosis, what is that we have discussed? The individual will develop a concentric left ventricular hypertrophy. So you will have the changes in the ECG in favor of the left ventricular hypertrophy, and that is nothing but we have a criteria where SV1 plus RV6, it should be more than 35 mm to call it as the left ventricular hypertrophy. And what is the name of the criteria? The name of the criteria is the Sokolov-Lyon criteria, right? So this is the name of the criteria for left ventricular hypertrophy. And apart from the ECG changes suggestive of the left ventricular hypertrophy, there will be also changes like the ST segment depression and as well as the T wave inversion. The presence of ST segment depression and as well as T wave inversion, they indicate the presence of the LV strain, right? And this particular LV strain pattern is mainly seen in lead 1, AVL, V5 and then V6. And the T wave inversion, it will be asymmetrical T wave inversion. That is what you will observe regarding the T wave. Whereas in which condition you will have symmetrical T wave inversion? Symmetrical T wave inversion you come across most commonly in case of the ischemia. whereas asymmetrical T wave inversion, it is very much suggestive of the strain pattern. So this is the ECG in left ventricular hypertrophy and as well as left ventricular hypertrophy secondary to aortic stenosis. So you can observe that SV1 plus RV5 or V6, any of these you can take. If it is more than 35 mm, that is suggestive of left ventricular hypertrophy. That is one thing. And ST segment depression, along with that, asymmetrical T wave inversion is suggestive of the strain pattern. And you have to understand a very important point is that there is no correlation between the ECG and hemodynamic severity of the obstruction. Okay, so it is not mandatory that if there is severe aortic stenosis, there should be a specific ECG changes. So there is no close correlation between the ECG and as well as the hemodynamic changes. H stands for hemodynamic changes in the aortic stenosis. And the another very important point is, if suppose, right, if there is absence of left ventricular hypertrophy changes, this does not exclude severe aortic stenosis. Right, this does not exclude severe aortic stenosis or the severe obstruction. So that is the importance of the ECG you need to understand. And most of the times, these particular patients with the aortic stenosis, they can also have coexisting systemic hypertension. And once there is coexisting systemic hypertension, that will also contribute to the development of the hypertrophy. And the next important investigation is the echocardiogram. Echocardiogram, right? So this is considered to be the first line investigation, right? And what does the echocardiogram demonstrate? It demonstrates the thickening and as well as the calcification of the valve leaflets, right? And this particular thickening and as well as calcification, it appears as a whitish plaque over the aortic valve. And the another important finding in the echocardiogram is that you will notice that there is reduced systolic opening of the aortic valve leaflets, and you will also notice that there is left ventricular hypertrophy. And another important point related to echocardiogram is that we will be able to make out even the left ventricular ejection fraction in patients with the aortic stenosis. So these patients with aortic stenosis, remember, they land up finally, as the severity of the aortic stenosis increases, they land up in what is called as the heart failure with reduced ejection fraction, where the ejection fraction of the individual is reduced to less than 40%, and that can be determined by the echocardiogram. And next very important is like the importance of the echocardiogram in determining or detecting the congenital bicuspid aortic valve. See, in young individuals, the most common cause of the aortic stenosis is the congenital bicuspid aortic valve. So how can you tell in the 2D echo that it is the bicuspid aortic valve? Because this bicuspid aortic valves, they have the extrinsic closure of the aortic valve cusps, right? There will be eccentric closure of the aortic valve cusps. That is how you will be able to determine the bicuspid aortic valve. And the next important investigation is the transesophageal echocardiography. Why? Why is that you want to do a transesophageal echocardiography? That is mainly for accurate characterization of the obstructed orifice. We will do the transesophageal echocardiography, right? And usually, most of the times, routinely this is not being done. Only in a doubtful cases or when you're planning for transcatheter aortic valve replacement or transcatheter aortic valve implantation, that is the point when we do this transesophageal echocardiography. And in the transthoracic echocardiography, what is the importance of doing the Doppler studies? See, the Doppler is the one which will measure what is the valve gradient that is between the left ventricle and as well as the aorta. And how much is the aortic valve area, even that also you will be able to make out by Doppler studies. Okay, right. Now you see, what is a normal valve area? Normal valve area is around 3 to 4 centimeters square. And we use the word mild aortic stenosis when the valve area is between 1.5 to 2 centimeters square. And when do we call moderate aortic stenosis? When the valve area is around 1 to 1.5 centimeters square, we call it as moderate aortic stenosis. And when the valve area is less than 1 centimeter square, we call it as severe aortic stenosis. Now, you will be also able to make out the jet velocity and as well as the peak gradient by the transthoracic echocardiography. Now, like in case of the aortic valve sclerosis, what will be or how much will be the aortic jet velocity and as well as the peak gradient? Okay, so before going on to the aortic valve sclerosis parameters, let me first tell you the normal values in a normal aortic valve. What is a normal aortic jet velocity? What is a normal mean gradient? And what is a normal valve area? And then subsequently in mild, moderate, severe, like what are these values, we'll try to discuss. So if you take the normal aortic jet velocity is 2 meters per second. That is a normal aortic jet velocity. And gradient will be less than 5 millimeters of mercury. And how much is the normal valve area we have discussed? That is 3 to 4 centimeters square. And when do we use the term mild? That is when the valve area is 1.5 to 2 centimeters square. When do we call moderate? That is when the valve area is around 1 to 1.5 centimeters square. And when do we call severe? That is when the valve area is less than 1 centimeter square. We call it as severe aortic stenosis. Then you take the gradient. Now, in a normal individual, the gradient between the left ventricle and aorta is less than 5 millimeters of mercury. And in case of aortic stenosis, right, in case of aortic stenosis, the gradient will be more than 10 millimeters of mercury. That is a criteria to call aortic stenosis. And in case of mild aortic stenosis, the gradient will be between 10 to 25 millimeters of mercury. Whereas in moderate, the gradient is around 25 to 40 millimeters of mercury. Whereas in severe, the gradient is more than 40 millimeters of mercury. Okay. So in severe aortic stenosis, the gradient will be more than 40 and the valve area will be less than 1 centimeter square. Whereas you take aortic jet velocity. Aortic jet velocity in a normal individual is less than or equal to 2 meters per second. And in mild, it will be 2 to 3 meters per second. Whereas in moderate, it is around 3 to 4 meters per second. Whereas in severe, it is more than 4 meters per second. Okay. So this is about the parameters of the aortic jet velocity in mild, moderate, severe. Now, when do we use the term the aortic valve sclerosis? We use the word aortic valve sclerosis when the aortic jet velocity is more than 2 and less than 2.5 meters per second. And how much should be the peak gradient? The peak gradient, it should be in a form of mild aortic stenosis, that is 10 to 25 millimeters of mercury, right? So these values are very important to determine whether it is mild, moderate or severe aortic stenosis, right? Now, the next important is, if suppose you have done a 2D echo, the 2D echo shows that the left ventricle, it is dilated and there is reduced systolic shortening of the left ventricle. What does that tells you? That reflects the impairment of the left ventricular function. Okay, if left ventricle is dilated and there is reduced LV systolic shortening, that represents the impairment of the left ventricular function, right? Now, in the recent days, we have what is called as the longitudinal strain pattern studies. Now, what is the importance of this longitudinal strain pattern studies? These longitudinal strain pattern studies, they will detect, right? They will detect the early changes in the left ventricular systolic function. before the decline in ejection fraction. Okay, before the decline in ejection fraction, longitudinal strain studies will detect, is there any changes in the LV systolic function? That is the importance of the longitudinal strain, right? Next, then followed by that, the another importance of transthoracic echocardiography is to diagnose the presence of any coexisting valvular abnormalities, because most of the time AS is associated with AR, or the AS can be associated with mitral valve lesions, that is MS or MR. So with the help of 2D echo, we will be able to diagnose even if there is any coexisting valvular lesions. And the next important is the transthoracic echocardiography also will diagnose the differentials for left ventricular outflow tract obstruction. Like, is it like valvular aortic stenosis, or is it sub or supravalvular aortic stenosis? That you will be able to make out by doing a 2D echo. And next is measurement of the aortic root is very, very important, right? And that to which part of the aortic root, that is the proximal ascending aortic dimensions, are very important. Now, in which clinical scenario measurement of the aortic root and as well as the proximal ascending aortic dimensions are very important? They are very important in patients with bicuspid aortic valve disease, because in these patients with bicuspid aortic valve disease causing aortic stenosis, the proximal ascending part of the aorta, it is dilated, and if it is dilated like more than 5.5 centimeters, and that's an indication for surgery, or it's an indication for surgical intervention. So that is the reason why measurement of the aortic root and proximal ascending aortic dimensions are very, very important, particularly in cases of the bicuspid aortic valve. And in the 2D echo, the another very important form of the aortic stenosis that we need to know is low gradient severe aortic stenosis with low left ventricular ejection fraction. Now, what is this? See, whenever there is severe aortic stenosis, how much should be the gradient? That should be more than 40 millimeters of mercury. But even though there is severe aortic stenosis, there is low gradient. Now, how is it possible? It is possible when there is left ventricular failure. It is possible when there is left ventricular systolic dysfunction. So, severe aortic stenosis, the valve area will be less than 1 centimeter square, right? And you take the gradient, it's a low gradient, so it is less than 40 millimeters of mercury. Normally in severe, how much it should be? More than 40, right? And this particular scenario you come across when the ejection fraction is less than 40%. Okay, why? Because when there is left ventricular systolic dysfunction, the pressure rise within the left ventricle will not be there. That is the reason why the gradient between the left ventricle and aorta will be not more than 40, even though there is severe aortic stenosis. And that we call it as low gradient severe aortic stenosis with low left ventricular ejection fraction. Now, this is again of two types, right? This is again of two types. So now what is this of two types is? Okay, so one we have low flow, low gradient with reduced ejection fraction. Okay, LF stands for low flow, LG stands for low gradient with reduced ejection fraction. That is what we have discussed, right? In which cases we are talking about this? In patients with severe aortic stenosis. And the other one we have, that is paradoxical, right? That is paradoxical low flow severe aortic stenosis with normal ejection fraction, right? Normal ejection fraction. Okay, normally when will you have this low flow low gradient? When the ejection fraction is reduced. But in spite of the ejection fraction being normal, still if there is low flow low gradient, remember that we call it as paradoxical low flow low gradient severe aortic stenosis. That is paradoxical. Understood? Okay. One more important point is, like, when do we use these words high gradient and as well as super severe gradient? Okay. So we use the word high gradient, already we have discussed, when the gradient is more than 40 millimeters of mercury and the aortic jet velocity will be more than 4 meters per second. That is one thing. Whereas when do you call super severe gradient? We use the word super severe gradient when the gradient is more than 55 millimeters of mercury and the aortic jet velocity is more than 5 meters per second. Okay, this we call it as super severe gradient, right? Then coming to your low flow, low gradient. So in this again, I said you two types, right? One is reduced ejection fraction, where the ejection fraction will be less than 50% or even less than 40% also. Whereas what is this paradoxical type? See, this paradoxical form is that which is associated with normal ejection fraction, where the ejection fraction is more than 50%. Okay, so this super severe gradient you need to be very much aware of. Next, followed by that, the very important investigation is the CT. What is the importance of doing CT? Now, if you want to do quantitative analysis of the calcium on the valve, then doing a CT is very, very important, right? Then the another important is the CT is very much useful to assess the aortic valve morphology and as well as the functioning of the aortic valve. And remember, before a patient undergoing TAVI, that is transcatheter aortic valve implantation, the investigation of choice to assess the aortic valve morphology and function, that will be the chest CT, right? Then, so that is about the importance of the CT scan. Next is, why is that you need to do a cardiac MRI in case of the aortic stenosis? That is mainly to screen the presence of, right, mainly to screen the presence of the myocardial fibrosis. And how can you detect that there is presence of myocardial fibrosis? That is by late gadolinium enhancement. So whenever there is myocardial fibrosis, there will be gadolinium uptake, there will be late gadolinium enhancement that you come across in patients with severe aortic stenosis. Okay, so the purpose of doing MRI is you need to do MRI along with late gadolinium enhancement in order to detect the presence of the myocardial fibrosis, right? Then what will be the changes that you will observe within the chest X-ray? Remember, in early stages, right? Remember, in early stages, most of the time the chest X-ray may show no or there will be overall little changes in the heart, right? Little changes within the heart. Okay, and when will you observe that, or in which particular view is good for determining the hypertrophy without dilatation? If suppose, if there is hypertrophy without dilatation, in a frontal view, you will notice that there is rounding of the cardiac apex. I'll show you that X-ray as well, right? Rounding of the cardiac apex. And so that is when there is hypertrophy without dilatation, and you will be able to determine that in the frontal view. Whereas in the lateral view, what is that you will observe? In the lateral view, there will be slight backward displacement, right? There will be slight backward displacement. That is what you will observe in the lateral view. Okay, so you see this particular X-ray, right? So you can notice here that there is rounding, slight rounding of the cardiac apex, that is in the frontal view. Whereas in the lateral view, right, you can observe that there is slight backward displacement, right? And another importance of the chest X-ray is, in the chest X-ray you will be also able to determine the presence of dilated proximal ascending aorta, and this you will observe along the upper right heart border, right? This you will observe along upper right heart border, right? And which view is important for this? That is, the frontal view is important, right? Next, the another importance of doing the chest x-ray is to determine the presence of the aortic valve calcification. And to determine the aortic valve calcification, which view is good? That will be lateral view. You will be able to pick up that aortic valve calcification. Now, as the severity or as the time of the aortic stenosis progresses, in the later stages, you will notice that there is left ventricular enlargement. But remember, in early stages, you don't see left ventricular enlargement. You will just see only a concentric hypertrophy, right? And not only the left ventricular enlargement, even there are some other structures which are dilated that you can observe on the chest x-ray. What are those? There will be LA enlargement, right? There will be enlargement of the pulmonary artery. You can also observe the presence of pulmonary venous hypertension, and there can be also enlargement of the right-sided chambers. So these are the other structures which are being dilated that you will be observing in the chest x-ray, right? Now, the next important is the cardiac catheterization. So if you see this cardiac catheterization, what is its importance? See, this is an invasive procedure, right? And this invasive procedure is not very much frequently used. This is useful only when there is discrepancy between the clinical and non-invasive finding. Okay, so you have clinically severe aortic stenosis, and your non-invasive investigations are showing that there is mild aortic stenosis. So if there is a discrepancy between these two, that is the only point when we do this invasive assessment of the aortic stenosis, that is cardiac catheterization. But whenever you are doing this cardiac catheterization, you need to be very much careful. That is, whenever you are trying to attempt, right, whenever you are trying to attempt to cross the aortic valve, right, whenever you are trying to attempt to cross the aortic valve, that is associated with increased risk of the cerebral embolization. Okay, whenever you are trying to attempt to cross the aortic valve, that is associated with increased risk of the cerebral embolization. Okay, so that is about your cardiac catheterization. And this cardiac catheterization, remember, it is useful in three distinct categories of patients. Number one, patients with multivalvular diseases. Okay, so patient having AS, patient having MS, right, and patient at the same time also having AR. So multivalvular problems are there. In such case, to plan the operative treatment, right, in such case, to plan the operative treatment, you require to do the cardiac catheterization. That is one thing. Second important is, like, for suppose there is a young individual with congenital bicuspid aortic valve, right? There is a young individual, asymptomatic individual with congenital bicuspid aortic valve. Now, in these patients, if you want to do PABV, that is percutaneous aortic balloon valvuloplasty, when you are planning for percutaneous aortic balloon valvuloplasty, in these cases, in order to determine, right, in these cases with congenital bicuspid aortic valve, in order to determine the severity of obstruction and whether to plan this PABV or not, you will be able to make out by doing the cardiac catheterization. So remember, in a young asymptomatic patients, right, young asymptomatic patients with non-calcific congenital aortic stenosis, to define the severity of the obstruction to the LV outflow because of See, you need to decide by doing cardiac catheterization whether to do surgery or whether to go ahead just with simple PABV. That you will be able to do by cardiac catheterization in case of congenital bicuspid aortic valve. And the another important indication for the cardiac catheterization is in a suspected case of the obstruction to the LV outflow, right? Like for example, if it is valvular aortic stenosis, then it is well and good, right? You don't have any problem there. You can perfectly do your TAVI. Whereas if you are in a doubtful, that means there is some other cause for left ventricular outflow tract obstruction. That is either subvalvular stenosis is there or there is supravalvular stenosis you are suspecting. Then in such case, whenever there is suspicion of sub or supravalvular aortic stenosis also, you need to do cardiac catheterization. So these are the three scenarios of the aortic stenosis you need to do cardiac catheterization. Number one, multivalvular problem to plan the treatment. Number two, bicuspid aortic valve to determine whether to do PABV or surgery. Number three, in order to determine whether if there is the sub or the supravalvular aortic stenosis, right? Next important is the coronary angiography. See, coronary angiography, what is the purpose of doing is, most of these patients with aortic stenosis, right, it is very commonly in the elderly individuals. And these elderly individuals, they have concomitant coronary artery disease as well. So mainly to screen for coronary artery disease, you need to do the coronary angiography, right? And particularly in which group of individuals? Like for suppose, this patient with severe AS who is symptomatic, right? He is symptomatic and you are planning for surgical aortic valve replacement, right? Or you are planning for transcatheter aortic valve implantation or intervention. In such case, you do coronary angiography. Why? Because when you are trying to do the surgical aortic valve replacement, if there is concomitant coronary artery disease, parallelly you need to do the coronary revascularization as well, right? Parallelly you also need to do coronary revascularization as well. So that is the purpose of doing the coronary angiography. And this particular coronary angiography, it is also useful for assessing, or it is also useful for hemodynamic assessment of the pressure changes within the or across the valve. Okay, so this is about your coronary angiography, and this completes the investigations in patients with the aortic stenosis. Now let me discuss the natural history of these patients with the aortic stenosis. See, those patients who are developing symptoms, they immediately have to undergo surgical intervention. Otherwise, once the individual develops symptoms, the prognosis is bad if the individual does not undergo the surgical intervention. Okay, right. And death in patients with severe aortic stenosis, it is very common around 7th or 8th decade. Right, it is very common around 7th or 8th decade. Now, if suppose, if the individual has not undergone surgical intervention, then what is the average time to death after the, development of symptoms? Okay, like for example, the individual has developed the angina pectoris, did not undergo any intervention. The average time to death will be 3 years. Okay, after the syncopal attack, the average time to death will be 3 years again, and dyspnea, average time to death will be 2 years, and the individual has developed heart failure, the average time to death will be 1.5 to 2 years. Okay, so this is the natural course of a patient with the aortic stenosis. But some of these patients with aortic stenosis, they can also undergo sudden cardiac death as well. Now, what is the reason for this sudden cardiac death? The reason for sudden cardiac death is mainly because of the development of arrhythmia. Okay, so this resulted from an arrhythmia, and this arrhythmia causing sudden cardiac death, it occurs in almost 10 to 20% of patients, right? However, most sudden deaths occurred in patients who had previously been symptomatic as well, right? Previously being symptomatic, in these individuals also right? The most sudden deaths are very common, right? And the presentation of the aortic stenosis in the form of sudden death itself as a first manifestation, it is very uncommon, and it is just seen 1% per year in asymptomatic adult individuals. Okay, right? So arrhythmia causing sudden cardiac death, 10 to 20% of individuals. Individuals previously symptomatic, there is chance of sudden cardiac death. But asymptomatic individuals presenting with sudden cardiac death as a first manifestation, it is just only 1%, and it is very uncommon, right? Then followed by that, you take this terminology called calcific aortic stenosis. See, calcific aortic stenosis, it is a progressive disease. Now, when you call it as significant progression, we call it as significant progression when the annual reduction in the valve area, if it is 0.1 centimeter square per year, right? That is, every year the valve area is reducing by 0.1 centimeter square. That is one parameter to call it as progressive disease. Then you take the peak velocity. If the peak velocity, if it is increasing at a rate of 0.3 meters per second, that also we call it as calcific aortic stenosis. And what should be the valve gradient to call it as progressive calcific stenosis? The gradient should be increasing at a rate of 7 millimeters of mercury per year. Okay, so these are the terminologies to call it as progressive calcific aortic stenosis, right? Now, then followed by that, very important part of the discussion will be the treatment. So if you see the treatment of the aortic stenosis, asymptomatic patients, how do you treat? Symptomatic patients, how do you treat? But before that, very important is the preoperative coronary angiogram. In case of symptomatic aortic stenosis, right, in patients with symptomatic aortic stenosis, whenever you are planning for surgery, either surgical aortic valve replacement or transcatheter aortic valve implantation, definitely preoperative coronary angiogram should be done. Okay, this should be performed routinely, right? Particularly when the age of the individual is on the higher side. Coronary angiogram is of very much clinical importance because there may be concomitant coronary artery disease also. Okay, and if the individual is symptomatic, yes, you need to do coronary angiogram to look for concomitant coronary artery disease, and in those individuals with coronary risk factors also, you need to do a preoperative coronary angiogram, right? And this importance of the coronary angiogram and cardiac catheterization lies mainly when there is discrepancy between the clinical and as well as the non-invasive finding. Clinically, the patient is like, it is appearing like there is severe aortic stenosis. Non-invasive investigations are showing that it is a mild aortic stenosis. If there is a discrepancy, then cardiac catheterization and coronary angiogram is of very important clinical importance, right? Okay, before going on to the operative or surgical interventions, let me first discuss the medical treatment. So in case of severe aortic stenosis, when do you call it as? When the valve area is less than 1 centimeter square. In these individuals, doing activities like strenuous physical activity and playing competitive sports, they should be avoided. Okay, so physical activity and competitive sports, they should be avoided even though the individual is asymptomatic, right? Even though the individual is asymptomatic, right, the physical activity and as well as competitive sports should be avoided. And next, very important is, you need to avoid the dehydration, and you also need to avoid hypovolemia. That is mainly to protect against significant reduction in the cardiac output of the individual. Okay, because once there is severe dehydration and hypovolemia, the left ventricular outflow tract obstruction also increases, right? and that will further cause significant decrease in the cardiac output. So that should be completely avoided. And what are the drugs that you need to give in asymptomatic individuals? So asymptomatic patients with preserved left ventricular systolic function. In those individuals, the drugs that you need to supplement is the selective beta 1 blockers, that is metoprolol and the atenolol. Then ACE inhibitors like prils, that is enalapril, ramipril, okay, these have to be supplemented. And the other group of drugs which are very important is the nitrates. What is the purpose of giving nitrates? The purpose of giving nitrates, that is mainly to reduce the angina, okay. And whereas you take the statins and as well as the RAS inhibitors, whenever you give the statins and RAS inhibitors, they slow the progression of the aortic stenosis, right? And it will also reduce the rate of progression. Basically it will reduce or slow the progression of the aortic stenosis. Okay, so that is about the statins and as well as the RAS inhibitors. Now, what is the indication for the infective endocarditis prophylaxis? Remember, the need for infective endocarditis prophylaxis is restricted to aortic stenosis patients, right? Patients with aortic stenosis with past history of infective endocarditis, right? Aortic stenosis with past history of the infective endocarditis. In this individuals, you need to give the infective endocarditis prophylaxis, okay? And what about the surgical treatment, right? What about the surgical treatment? Now let me discuss the surgical treatment. Now, in asymptomatic patients, do you require surgical treatment? Usually no. Then what is that you need to do in case of asymptomatic patients? Asymptomatic patients with calcific aortic stenosis, those individuals having severe obstruction, you need to do careful follow-up with the two-dimensional echocardiography. And in the two-dimensional echocardiography, what is that you need to monitor? You need to monitor the evidence of deteriorating LV function, right? You need to monitor the evidence of deteriorating LV function. That is what you need to check in the two-dimensional echocardiography in a patient with severe obstruction and asymptomatic calcific aortic stenosis. Now, what are the indications for surgical intervention then? So, the indications for surgery include, number one, severe aortic stenosis being symptomatic. Severe means the valve area less than 1 centimeter square and gradient more than 40 millimeters of mercury. Symptomatic aortic stenosis, you need to do surgery. Then, those who exhibit LV systolic dysfunction, right, where the ejection fraction is less than 50%, they have to undergo surgery. Then those with aortic stenosis due to bicuspid aortic valve and an aneurysmal root or the ascending aortic root or ascending aorta, the dimension more than 5.5 centimeter, they also have to undergo surgical intervention. This is what we were discussing even in the 2D echo also. So in the 2D echo, the determination of the aortic root dimension and as well as the determination of the ascending aortic dimension is very, very important, because if the dimension is more than 5.5 centimeter, they are the candidates who require surgical intervention, right? Then, now the another thing is indications for operation in case of the presence of the aortic aneurysms. If there is smaller aortic diameters like 4.5 to 5 centimeters, for patients with family history of aortic catastrophe in the form of aortic dissection, in the form of aortic rupture, if they are having aneurysm, they have to undergo surgical intervention. And patients who exhibit rapid aneurysmal growth. What do you mean by the word rapid aneurysmal growth? That is the growth of the aneurysm at a rate of more than 0.5 centimeters per year. So they also have to undergo the intervention. Okay. So this is about the indications for operation in a case of the aortic aneurysm. So number one, family history of the aortic catastrophe. Number two, patients who exhibit rapid aneurysmal growth. Now, apart from this, the other area where you need to do the aortic valve replacement, even though asymptomatic. See, usually what did I tell you? Most of the time, asymptomatic individuals with aortic stenosis, they don't require the aortic valve replacement. But asymptomatic aortic stenosis, that is moderate or severe aortic stenosis, and this particular patient is getting planned for coronary artery bypass graft, then along with CABG, you also need to do the aortic valve replacement also. Because why? Even though asymptomatic you are doing here, because these asymptomatic moderate or severe AS, at one point of time they become symptomatic severe AS also. So now you are doing CABG. Later again, if you want to do aortic valve replacement, doing repeated sternotomy and opening the chest, like there will be formation of the adhesions and the surgical approach may not be proper when you want to do a redo operation on the aortic valve. So that is the reason why at the time of doing a CABG itself, if there is moderate and severe asymptomatic AS, go ahead with the aortic valve replacement as well, right? Then the next important is coming to the surgical intervention. Actually, surgical interventions, we have two types. One is SAVR, that is surgical aortic valve replacement. The other one is TAVR or TAVI, that is transcatheter aortic valve implantation or transcatheter aortic valve replacement. So you take the operative risk of the surgical aortic valve replacement. The operative risk of surgical aortic valve replacement is around 2%, right? It is around 2%. But remember, the operative risk of surgical aortic valve replacement, it increases with the age of the individual, right? It increases with the age of the individual, and the operative risk also increases when there is concomitant aortic and other heart valve surgery, or when the patient is also undergoing parallel CABG. So remember, otherwise your operative risk is only 2%. But if there is the age of the individual keeps on increasing, or if there is associated surgeries that need to be done, then the mortality further increases. Now, apart from absolute indications for surgery, now you need to know what are the relative indications for surgery. The relative indications, if you observe, number one, abnormal response to treadmill test. What do you mean by that? Normally, whenever an individual does a treadmill test, the systolic blood pressure increases. It increases at least more than 10 millimeters of mercury. But in scenario where you are doing a treadmill test in a patient with severe aortic stenosis, but there is no increase in the blood pressure because of severe obstruction, then he is a candidate to undergo surgical intervention. Next, rapid progression of the aortic stenosis, especially when urgent access to medical care might be compromised. Okay, you are in a fear that at the time of requirement, the medical care may not be done to the individual, then also you go ahead with the surgery. Then very severe AS defined by an aortic valve jet velocity more than 5 meters per second or mean gradient more than 60 millimeters of mercury and low operative risk, go ahead with the surgery even though the individual is asymptomatic. That we call it a super severe gradient or super severe aortic stenosis. And excessive left ventricular hypertrophy in the absence of severe systemic hypertension, go ahead with the surgery. These are all only relative indications. These are not the absolute indications. And there was a small randomized control trial which was done. And what was this trial about? This trial has compared early surgery versus conservative care for asymptomatic patients with very severe aortic stenosis. So what is the criteria to call it as very severe aortic stenosis? The criteria what they have taken is the aortic jet velocity is more than or equal to 4.5 meters per second. Mean gradient is more than or equal to 50 millimeters of mercury. And aortic valve area is less than or equal to 0.75 centimeters square. Okay. Now, what they have found as a result, what they found at the result is the rate of operative death or death from cardiovascular causes during the follow-up was reduced with early surgery. Okay, reduced with the early surgery. Whereas you take in case of conservative care group, in conservative care group, there was mortality being present. What percentage? See, the cumulative incidence of the sudden death was 4% at 4 years and 14% at 8 years. So that was the cumulative incidence of the sudden death in the conservative care group. Okay, so that was a small randomized control trial for very severe aortic stenosis patients, right? Next, the very important thing that you need to know is operation should be carried out promptly if the patient is having symptom onset, within how many days of symptom onset the operation should be immediately done? It should be done within 1 to 3 months of, right, within 1 to 3 months after the symptom onset, the operation should be carried out promptly. And what should be the flow? The required flow more than 35 ml per meter square. And what is the required gradient to go ahead with the surgery? The gradient should be more than or equal to 40 millimeters of mercury. So these are straightforward clinical decision making parameters. Gradient more than 40, right? Symptom onset, go ahead with the surgery within 1 to 3 months, right? Whereas you take the story in, okay, before that, let me just give you a table of the mortality risk in patients who are undergoing the aortic valve surgery. So you take in patients who have undergone only aortic valve replacement, isolated aortic valve replacement. In them, the mortality risk is 1.9%. Whereas in patients who have undergone aortic valve replacement along with that coronary artery bypass graft, in such case, the mortality rate is around 3.6%. Right? In such case, the mortality rate is around 3.6%. Okay? Right. Next. Now, coming to the story of the mortality rate or the outcome in patients with low flow, low gradient severe aortic stenosis with reduced left ventricular ejection fraction. Remember, in this group of individuals, low flow, low gradient with reduced ejection fraction, the perioperative mortality rate is very high. Why? Because the patient is having the LV systolic dysfunction. And how much is that mortality rate? That is nearly around 15 to 20%. Okay. And the evidence of the LV dysfunction, whether is it present even after the surgery? Yes. Right? The evidence of the LV dysfunction, it persists even post-operatively also. It doesn't mean that once you have done an aortic valve replacement, the LV dysfunction immediately changes. No. Right? And how will be the long-term post-operative survival in this individual? See, long-term post-operative survival completely depends upon pre-operative, right? Completely depends upon pre-operative left ventricular function. Okay, completely depends upon pre-operative left ventricular function. Okay. Next is the importance of dobutamine stress echo in valve replacement. Okay. See, in which group of individuals you do this dobutamine stress echo? That is mainly in low flow, low gradient, severe aortic stenosis. Right? Low flow, low gradient, severe aortic stenosis. In them, you have to do the dobutamine stress echo. What is the purpose of it? Let me tell you. Now, in patients with low flow, low gradient with reduced ejection fraction, the outcome is bad. The prognosis is poor. Right? Now, when you do aortic valve replacement or TAVI, is it useful or not? Because the survival of the individual is not great. So, is it actually useful to do the aortic valve repair or replacement or TAVI? How can you decide is by doing the dobutamine stress echo. Within the dobutamine stress echo, if there is increase in stroke volume more than 20%, then you go ahead with the aortic valve replacement in patients with low flow, low gradient severe aortic stenosis with reduced ejection fraction. Okay. So the purpose of doing dobutamine stress echo is whether to do surgery or not in a patient with low flow, low gradient severe aortic stenosis with reduced ejection fraction. If the DSE shows that there is increase in stroke volume more than 20%, then go ahead with the surgery. Right? Then patients in this high surgical group are usually treated with TAVI because they are high risk individuals. they cannot tolerate that sternotomy and as well as surgical aortic valve replacement. In them, better to go ahead with the transcatheter aortic valve implantation. And the management of patients with low flow, low gradient, severe aortic stenosis with normal ejection fraction, right? It is still challenging task, right? It's a challenging task. In these patients, what you have to do? You can do either SAVR or TAVI. Any of these can be done. But whereas in those individuals with reduced ejection fraction, go ahead with the TAVI. So whenever you do this SAVR, that is surgical aortic valve replacement or TAVI, compared to medical care, right? Compared to medical care, the outcome is good when you do either SAVR or the transcatheter aortic valve implantation. So normal ejection fraction with low flow, low gradient severe AS, what do we call it as? Paradoxical low flow aortic stenosis, right? Then in patients whom severe aortic stenosis and coronary artery disease coexist, in this group of individuals, along with doing the repair of the aortic valve, right, along with doing the repair of the aortic valve, you also need to plan for you also need to plan for revascularization. Okay, that is very, very important. See, once you do revascularization along with the aortic valve repair, if there is a coexisting coronary artery disease, there is a very good hemodynamic improvement, right? There is a very good hemodynamic improvement, okay? Because many patients with calcific aortic stenosis are elderly individuals, and particular attention must be directed to the adequacy of the hepatic impairment, because these patients, they also have the hepatic and as well as the renal impairment, and you also need to check for the pulmonary function test before aortic valve replacement is recommended. So before doing this, you need to do the all system workup. And the perioperative mortality rate completely depends upon the preoperative clinical status. Okay, the post-operative mortality rate, it completely depends upon patients, right? Patients preoperative clinical and hemodynamic state, right? Clinical and hemodynamic state. Okay, and what is the 10-year survival rate? The 10-year survival rate of older adult patients with surgical aortic valve replacement is nearly 60%. That is the importance of your surgical aortic valve replacement. Now, when you are doing surgical aortic valve replacement, which valves have to be placed, right? Is it like biological valve or bioprosthetic valve, or is it the mechanical valve? So it all depends upon the age of the individual. It all depends upon the risk of the anticoagulation. See, biological valves, the requirement of redo surgery is very high, because the bioprosthetic valve viability or the life is only just 10 years. That is the reason why these biological valves are placed mainly in the elderly individuals. But the only advantage of the bioprosthetic valve is that the anticoagulation is not required, right? Anticoagulation is not required. Whereas you take the mechanical valve life is very long. It can be even up to 30 to 40 years. That is the reason why mechanical valves are preferred in young individuals. Okay, but these patients who are on mechanical valves, they have to be placed on the anticoagulation. Why? Mainly to decrease the risk of the thromboembolism. And these young patients, they can tolerate the anticoagulation. So you place the mechanical valve and start the anticoagulation. But whereas elderly patients, they cannot tolerate the anticoagulation. There is risk of bleeding. That is the reason why you place the bioprosthetic valve and don't give any anticoagulation. Okay. And for patients age more than 65 years, Which is the valve that is being preferred? That is bioprosthetic valve is being preferred. Okay, bioprosthetic valve is being preferred. And what did we discuss just now? The bioprosthetic valve, right? The lifespan is only 10 years. Almost 30% of patients, they require replacement. Right? 30% of patients, they require replacement. That is valve in valve surgery is very much required, right? Whereas you take this mechanical prosthesis, almost similar percentage of individuals, 30% of individuals, they develop hemorrhagic complications, right? They develop hemorrhagic complications with oral anticoagulation. That is with your vitamin K antagonist like warfarin, okay? And which group of individuals you need to do homograft aortic valve replacement? Homograft aortic valve replacement is usually reserved for patients with aortic valve endocarditis. So in patients with aortic valve endocarditis, you know, in them homograft aortic valve replacement is required. Now, next is, let me tell you what is Ross procedure and which group of individuals Ross procedure is required. I'll tell you. What is Ross procedure? First of all, it involves replacement of the diseased aortic valve with autologous pulmonary valve. Right? With autologous pulmonary valve. And in the area of the pulmonary valve, you need to do, right? You need to do implantation of, right? Implantation of the homograft in the native pulmonary position. So what is that you are doing? You are taking the patient's own pulmonary valve and you are placing it in the aortic valve area, and pulmonary valve of some other individuals you are taking and you are placing it in the native pulmonary position. So that is what is called as the Ross procedure. Which group of individuals require Ross procedure? I will tell you. But this particular Ross procedure is associated with certain late post-operative complications. What are those late post-operative complications? Number one, aortic root dilatation, right? Number two, aortic regurgitation. Number three, pulmonary homograft stenosis. Right? Pulmonary homograft stenosis. So these are the late post-operative complications in patients with who have undergone the Ross procedure, right? Then what is the another method of surgical intervention in case of the aortic stenosis? That is percutaneous aortic balloon valvuloplasty. What is that you will do? You just place a balloon along the stenosed aortic valve. You open the balloon, that means you will dilate the aortic valve and you deflate the balloon and take out the balloon. That is what is your percutaneous aortic balloon valvuloplasty. And this procedure is preferable in individuals, children with aortic stenosis, right? And this also be useful in non-calcific aortic stenosis like bicuspid aortic valve, okay? So congenital aortic stenosis. So in these cases, your percutaneous aortic balloon valvuloplasty, it can be done. Remember, this ballooning procedure is not recommended as definitive therapy whenever there is very high restenosis. The problem with the ballooning is there is very high chance of restenosis. Right? There is very high chance of restenosis. What percentage you know? Almost 80% restenosis in 1 year. That is a chance of restenosis with balloon valvuloplasty, right? So this particular balloon valvuloplasty is not recommended as a definitive therapy in adults with severe calcific aortic stenosis. right? Calcific aortic stenosis, balloon valvuloplasty should not be done, right? Should not be done, okay? And this will be acting as a bridge, or this procedure will be acting as a bridge in patients who are having severe LV dysfunction and planning for transcatheter aortic valve replacement or surgical aortic valve replacement. So this balloon valvuloplasty will be acting as a bridge in these group of individuals, right? Now, let me talk about the transcatheter aortic valve replacement. See, this transcatheter aortic valve implantation or replacement, it has completely surpassed the surgical aortic valve replacement in the treatment of aortic stenosis. And particularly this TAVR or TAVI is very much useful in a high surgical group, right? In a high surgical risk spectrum, right? In these patients, TAVI is very much preferable, okay? And those individuals, even with prohibitive group of surgical aortic valve replacement, in them also you better go ahead with the TAVI. But in the recent times, this particular TAVI is also being done in the intermediate or even in case of low risk individuals also. And what about the application of TAVI in asymptomatic aortic stenosis? Still, it is under investigation. Whether TAVI, can we do it in the asymptomatic individual or not? Still, it is under investigation. And this particular TAVI, that is transcatheter aortic valve implantation, we have two types of balloon valvuloplasty procedures. That two types of balloons. After doing the valvuloplasty by a balloon, then a valve is being placed there. So we have balloon expandable valve and as well as self-expanding valve, right? These are the two systems which are being present. So initially, with the help of a balloon, we expand the valve and then the valve is being implanted, right? So you have this image A and as well as the image B. Out of this, you take the first image, that is a balloon expandable valve, right? So this is a balloon expandable valve of TAVI and this is self-expandable valve. So these are the two types of the valves in the TAVI. And whenever you're doing the TAVI, what is the preferred route? See, there are many routes through which you can pass the catheter up to the level of the aortic valve, but which is the preferred route? The preferred route is the transfemoral route, right? And what are the other routes? The other routes are trans-LV apical, right? Next, subclavian route. Next, carotid route, right? Carotid route, and the other one is right, and the ascending aortic routes have been used. So these are the various routes of the TAVI, but which is preferable? That is transfemoral route is very much preferable, right? And what is the procedural success rates? The procedural success rates exceed 95%, right? Exceed 95% in appropriately selected patients, right? And what about in patients with bicuspid aortic valve? Okay, this particular technology of TAVI, it is being increasingly used in patients with bicuspid aortic valve as well. Now, if you take the graph of, like you see, a patients who have undergone TAVI, that is TAVR, or surgical aortic valve replacement. Now, this will be, the x-axis is months since procedure and y-axis is death, stroke or rehospitalization. So as the time progresses, with the TAVR, the chances of rehospitalization, the chances of death, the chances of stroke is less for TAVR when you compare that with the surgery. So the preferable method of surgery in these days is the transcatheter aortic valve replacement. And if you take the advantages of TAVI over the surgical aortic valve replacement, number one, these patients who have undergone TAVI, they have fewer peri-procedural deaths. Right? Number two, these patients, they have lower risk of stroke. And these patients with TAVI, they also have lower risk of major bleeding. Right? So this will be the advantages of the TAVI over the surgical aortic valve replacement. And not only that, you take the hospital length of stay is being shorter, and return to the normal activity is more rapid with transcatheter aortic valve implantation. Then even your surgical aortic valve replacement have few advantages over the TAVI. What are those? Remember, the requirement of pacemaker, right? The requirement of the permanent pacemaker is less with surgical aortic valve replacement compared to that of your TAVI. Then risk of perivalvular aortic regurgitation, it is less with surgical aortic valve replacement than with TAVI, and there is also lower vascular complications with surgical aortic valve replacement. Okay, so this will be the advantages of surgical aortic valve replacement over transcatheter aortic valve implantation. Now let me just show you a table of which group of individuals they favor surgical aortic valve replacement, which group of individuals they favor TAVI, in which group of individuals palliative treatment will be enough. Let me just show you a table. So factors favoring surgical aortic valve replacement, TAVI or palliative care in patients with aortic stenosis. So this table is directly from Harrison. So now those individuals having young age, longer life expectancy, SAVR is preferable. Whereas older age and fewer expected remaining years of life, TAVI is better. And very limited life expectancy, just palliative treatment. Then depending upon the valve anatomy. So if it is calcific trileaflet aortic stenosis, better to go ahead with the TAVI. Whereas bicuspid aortic valve, subaortic calcification, rheumatic valve disease, or small or large aortic annulus is there, better to go ahead with the surgical aortic valve replacement. Then prosthetic valve preference. In case of the TAVI, it is bioprosthetic valve which is being preferred. Whereas in SAVR, mechanical or surgical bioprosthetic valve depending upon the age of the individual. Young age, mechanical valve. Elderly individual, bioprosthetic valve, right? Then concurrent cardiac conditions, like if there is severe calcification of the ascending aorta, right? If there is severe calcification of the ascending aorta, preferable to go ahead with the TAVI. Whereas if there is aortic root dilatation, severe primary MR, severe coronary artery disease, septal hypertrophy requiring myomectomy, atrial fibrillation is there, in such case better to go ahead with the surgical aortic valve replacement, right? Then non-cardiac conditions, like if the patient is having associated lung pathology, liver pathology, renal pathology, morbidity issues, better to go ahead with the transcatheter aortic valve implantation rather than surgical aortic valve implantation. And next important is the frailty. The individual is highly frail. Frailty, it likely to improve after the TAVI. And SAVR, it is better, that is surgical aortic valve replacement, it is preferable in those individuals who are non-frail and few frail measures. Those individuals who are having severe frailty, they are unlikely to improve even after the TAVI as well. In them, the palliative procedures or palliative treatment will be enough. And estimated risk of surgical aortic valve replacement or TAVI. So for surgical aortic valve replacement, the risk is low in case of bicuspid aortic valve or rheumatic pathologies or subvalvular pathologies or supravalvular pathologies, right? Whereas TAVI is low to medium in case of high risk individual with aortic stenosis, right? Then procedure specific impediments. Now valve anatomy, annular size or low coronary ostial height, these patients they require surgical aortic valve replacement. And previous cardiac surgery with at-risk coronary grafts, transcatheter aortic valve implantation is being preferred. Okay, so this is about in which group of individuals you need to do SAVR, which group of individuals TAVI, which group of individuals palliative treatment. And there is also a flow chart, right? So you see this particular flow chart, right? A patient with aortic stenosis, this is also a table directly from the Harrison, and symptomatic is, and he is a candidate for aortic valve replacement. Now the surgical team and as well as the heart valve team, they have to decide whether to undergo TAVI or whether to undergo SAVR. If suppose if there is a very high or prohibitive surgical risk, then better to go ahead with the TAVI. That is a class 1 indication. The quality of life is good, in the sense life expectancy is more than 1 year, go ahead with the TAVI. But life expectancy is not good, then high risk individual, just palliative care will be enough. Now you take the other group. So in other group, like estimated risk not extremely high or prohibitive. See, mainly in high risk individual or prohibitive risk individual, better to go ahead with the TAVI. Understood? But if the high risk or prohibitive risk is not that high, then you need to decide about the vitamin K anticoagulation. If suppose if the individual is in a state that where he cannot take vitamin K antagonist, or if there is increased risk of bleeding, bioprosthetic valves are preferred, right? If suppose vitamin K antagonists are okay, he is able to take that, then in such case, if the age of the individual is more than 65 years, preferable to go ahead with the bioprosthetic valve. But if the age of the individual is between 50 to 65 years and he is okay with the vitamin K antagonist, then surgical aortic valve replacement in the form of mechanical valve is being preferred. And age of the individual less than 50 years, mechanical aortic valve replacement or pulmonic autograft, that is Ross procedure, is being preferred. Okay, so this is about which group of individuals have to undergo which procedural methods. So this is about the treatment of the aortic stenosis. So in this entire topic of the aortic stenosis, what all we have discussed, right? Very important is the etiology. Elderly individual, most common is calcific degenerative aortic valve. Young individual, bicuspid aortic valve. And if you take the pathogenesis, it is systolic dysfunction, right? There will be diastolic dysfunction and as well as the systolic dysfunction as well. And it's the individual with fixed cardiac output. And there is significant left ventricular hypertrophy, and that hypertrophied left ventricle is arrhythmogenic. And clinical features, that is SAD, syncope, angina and dyspnea. And the sequence will be in the thus. What is thus? Dyspnea, angina and as well as syncope. This will be the sequence of development of the clinical features. And on examination, you have that pulsus parvus et retardus, narrow pulse pressure, systolic hypotension. The LV apex will be in the normal position. In the later stages, it will be deviated. And you have double apical impulse, soft A2 will be there, narrow split, there can be single S2 and there can be paradoxical split also in very severe aortic stenosis. And ejection systolic murmur, which is low pitched, rough, rasping in character. Gallaverdin phenomenon you need to be very much aware of. And in the investigation, first line investigation will be 2D echo, confirmatory will be catheterization, but this is done only when required, right? And the treatment is asymptomatic individuals, they don't require any surgery, medical management is enough. But symptomatic individuals, they have to definitely undergo surgery within 1 to 3 months of development of the symptoms. So this completes the discussion of the aortic stenosis. Thank you very much.